Immediately, we will jump to the next presenter, Salwa Musa, who is a PhD student from the University of Alberta. And again, if you have any questions, put them in the app. I can read them here. Thank you.
Okay. So I'm here to speak about synthesizing the research addressing the unique needs of African, Caribbean, and Black. We use the acronym ACB, populations in Canada, accessing substance use and harm reduction services, a review of the existing literature right now. So, as mentioned, I'm a doctoral student at the University of Alberta, and the University of Alberta respectfully acknowledges that we are situated on Territory 6, Treaty 6 territory, traditional lands of the First Nations and Métis people. And I also want to acknowledge as well that nearly 54,000 Canadians and many more around the world have died from the drug toxicity crisis and supply, and then the families and communities who are grieving their passing. So my positionality with my work, so I am a PhD nursing student. I'm a public health nurse with 17 years of experience. I consider myself an ally for people who use drugs and their families. And then my positionality in the context of ACB populations, I'm a nationalized Somali refugee residing in Toronto, Ontario. So a little bit about the drug poisoning crisis in Canada. There's 53,000 apparent drug-related deaths as well. And this is all linked to the drug toxicity crisis and the harmful drug policies also within Canada as well. And there are additional social and health and harms linked to the substance use as well. So Canada is in the midst of unprecedented drug poisoning crisis, which is driven by the toxic, unregulated supply. So on average, there's about 18 opioid toxicity deaths every day. And in this image, you can see that some areas are more affected, or with the data that shows that they're having increased prevalence: Ontario, BC, and Alberta. But rates are rising throughout all of Canada, and beyond the deaths, the crisis strains emergency community health services and deepens existing mental health, housing, and social inequities. Sorry, the print is too small for me to read from this far. So a little bit of background. So the drug poisoning crisis, as I mentioned, is escalating in Canada. And in particular, African, Caribbean, and Black communities face disproportionate harms and systematic barriers while accessing harm reduction and treatments services, which are greatly limited and inequitable within the provinces and within Canada. So this review examines the barriers, the facilitators, and some strategies needed to strengthen harm reduction and substance use services within African, Caribbean, and Black populations in Canada. And I want to highlight that I use the term African, Caribbean, and Black quite frequently, but in the literature, especially in drug policy, you will see Black populations, and you will see African Americans also used too as well. And I think ACB is more of the community-informed term that encompasses the variety of Black populations in Canada. So the methods for this review was a narrative review guided by FRI 2015 framework, and we examined peer-reviewed and gray literature from 2010 to 2024, the focus on African, Caribbean, and Black populations, people who use drugs, and harm reduction services. In Canada, there wasn't that many articles and services that were published and in gray literature, so we had to add US data to help understand the complexities experienced by these populations. We focus on service access, retention, equity, and race-based data reporting. And we excluded prevention-only studies and those that were not focusing on an equity-focused service lens, and then those that were unrelated to substance use. So that we examined 870 abstracts, 324 full texts were assessed for eligibility, 132 were excluded, and 31 were not retrievable due to the various reasons listed above. And finally, we had 196 studies for the final review. So key findings. So there were 4 key findings that highlighted some of the impacts regarding the drug poisoning crisis and toxicity crisis towards African, Caribbean, and Black populations. And some of them were already highlighted in some of the presentations earlier. So there is systemic racism within our healthcare system, socioeconomic and geographic barriers, the criminal legal involvement as well within the war on drugs, and then the cultural stigma as well, all impact the population. So across the literature, systemic racism and stigma consistently emerges as one of the key barriers which fosters mistrust with accessing healthcare services. And it discourages African, Caribbean, and Black communities from seeking services, asking questions, and even staying in treatment after they seek services. Even with medications to support opioid use disorders, African, Caribbean, and Black patients are still less likely to start or remain in care, reflecting persistent inequities in accessing treatment as well. Another key barrier was the geographic and structural conditions that create major barriers for communities in accessing harm reduction and medication assistive programming. Many Black communities face what we call service deserts, where treatment facilities are scarce or non-existent, forcing people to have to travel long distances or spend significant time and money to access services. These challenges are often compounded by poverty, unemployment, and the housing instability that make it very difficult to engage in treatment. Lack of insurance or underinsurance also further limits access in the US population and can be seen also in some Canadian populations. And housing instability in particular undermines retention as individuals cycle between treatment and relapse when their basic needs remain unmet. These findings highlight that harm reduction cannot stand alone and substance use services can't stand alone. It must be paired with housing, income supports, and broader policy interventions to effectively reach these communities. And then the third key finding is that incarceration disrupts continuity of care. So when treatment such as methadone and ibuprofen is interrupted during custody, individuals face an increased risk of overdose, in particular at risk, at release. Black people are disproportionately affected because of systemic overrepresentation in the criminal legal system, which we just heard in the previous presentation, and ongoing inequities in accessing services, both inside and outside correctional settings. Research also shows the lack of coordinated re-entry supports undermines retention and treatment and contributes to elevated mortality risk post-release. These findings underscore the urgent need for continuity of medication-assistive services in correctional facilities, and really importantly, the link of community-based harm reduction and substance use services on release to prevent this preventable overdoses. And the fourth key finding is cultural stigma in communities. So beyond systemic racism and structural barriers, cultural stigma within African, Caribbean, and Black communities also discourage people from seeking treatment. Substance use is often seen as a moral weakness or family shame, which fosters secrecy, reluctancy in engaging with formal services. Faith and community norms also play a strong role in shaping treatment decisions. Programs that overlook these dynamics risk low participation and high dropout rates. On the other hand, family and community-centered interventions have shown better engagement and retention, demonstrating that tailoring harm reduction and substance use services to cultural and community contexts while directly addressing stigma is essential for meaningful uptake. So the lack of culturally focused care in Canada was very apparent with the data that we were able to find, where in Canada, there was only 9 peer-reviewed articles that spoke to this, and 3 gray literature that we pulled as well, meaning that majority of the articles, 180, came from the US, which showed that there were far greater cultural informed services in the US. This gap shows that Canada lags behind. Gray literature does help fill some gap, but showing that we do have an urgent need for culturally adoption and community-led approaches. Taken together, this evidence underscores the importance of culturally responsive, equity-driven harm reduction programs in Canada to address systemic gaps and improve health outcomes for African, Caribbean, and Black populations. So some successes that were found into the literature as well. I want to highlight cultural responsive programs. The one program that was found in Canada, SAPASI or Imani, is in Toronto, and community-wise, also another program in the US, show how youth-focused, community-based, and peer-led models improve trust and engagement. Faith-based approaches, such as the Imani Project in the US, further highlight the value of spirituality and peer support embedded into treatment. On the access side, having flexible models like audio, medication, accessible treatments, recovery management checkups integrated into the programs, and naloxone distributing programs dedicated to Black populations reduce barriers and save lives. Together, these examples show that African, Caribbean, and Black-focused services and culturally safe, community-driven programs are the most effective to supporting Black populations who use drugs. So some recommendations from the review. Based on the evidence, several key recommendations emerge. First, Canada must expand culturally responsive harm reduction services that reflect the realities of African, Caribbean, and Black populations in Canada. So integrating race-based data, such as surveillance, which is limited in Canada, into the evaluation is essential for tracking inequities and progress. One key finding, too, is workforce diversity and anti-racist training can strengthen trust and improve care delivery. Scaling community-led models ensures programs are grounded in the lived experience of the communities in which they serve and respond to the local needs of the very diverse population that encompass African, Caribbean, and Black populations in Canada. And then finally, systemic inequities. We need across healthcare, housing, and the justice system must be addressed to create conditions where harm reduction and substance use services can be effective and sustainable. So in conclusion, African, Caribbean, Black populations face systemic inequities in Canada to substance use and harm reduction services. The evidence is very limited in Canada, and the US literature does help to fill in some important gaps and highlight promising approaches. What we do know points towards cultural safe and anti-racist community-based models as key strategies to improve engagement and outcomes. But evidence alone is not enough. Policy action is urgently needed, especially with the changing in some of the service provisions that are happening right now. And we need to ensure equity and harm reduction to improve the health outcomes of African, Caribbean, and Black communities. So I'd like to acknowledge my supervisors, Dr. Heather Morris and Dr. Joanne Olson, for their guidance and mentorship through this narrative review and my doctoral studies. And I'm also extremely grateful for my collaborators, Dr. Julian Kola and Dr. Elizabeth Onyango as well, for their expertise in strengthening this work. My research is also supported by a strict doctoral award and an INSU trainee scholarship as well. And most importantly, my work is informed by the community partners and participants in African, Caribbean, and Black people who use drugs. Without their voices, experiences, this work would not be possible. And my hope and for my work is to strengthen their voices and be an ally in this space. Thank you.